Hello, welcome to Pathagonia. This is Jay, and thank you to Path Presenter for the slide of Alveolar Soft Part Sarcoma. And I'm going to use the NCCN version 2 of 2023 for some of the references. Let's get to it. First board fodder that we need to know is that the translocation, it's X17, ASPSCR1-TFE3. Again, ASPSCR1-TFE3. But that being said, you know how boards are, right? They test very, very rare things, and this is a very rare tumor, accounting for approximately like less than 1% of soft tissue tumors. It's currently classified as uncertain etiology, so we're not sure exactly what cell it arises from. It generally happens in children and young adults. In young adults, it happens in like the thigh or the deep, in the buttocks. And then for children, it happens in the head and neck regions. So let's get to it. On low power, we see these fibrous septae that has some vessels inside. And then surrounding these fibrous septae, we have kind of nested little packets of cells. So, and around also we have a background of kind of a lot of vasculature. So let's zoom in. So there's like delicate little septae has a lot of kind of very thin vessels. And then if we look at these kind of nests of cells, they kind of remind you of alveolar. So kind of the architecture is pseudo-alveolar. In the periphery, you have the cells that attach, and then you have these middle cells that kind of detach, slough off. Personally, I like to think of it as kind of reminds me of like that solid pseudo-papillary neoplasm of the pancreas that you see, that kind of like sloughing. But cytologically, it looks much different. We see eosinophilic cytoplasm, and sometimes you'll have like these cytoplasmic vacuoles. I don't see really good ones here. But in addition, you will have prominent nucleoli. Like you could see that bad boy from afar, but as we zoom in closer, you can see a lot of these have prominent nucleoli. So, alveolar soft part sarcoma, thing to know that it has a greater propensity to metastasize to the brain, and that's why clinicians will do imaging of the CNS as well to assess for metastasis. And what's important for us once we receive the specimen is that to make sure that there are negative margins, because if there are positive margins and if surgery doesn't limit the kind of functionality of the patient, they will get additional margins as well. So in terms of, if you're not sure based on the architecture and the cytology, you can do a TFE3 stain, because again, this translocation is X17, ASPSCR1-TFE3. So TFE3 will stain nuclear, and you can also do a PAS, and it'll stain that kind of eosinophilic cytoplasm. Your differentials are metastatic renal cell carcinoma, melanoma. You also can think of embryonal rhabdomyosarcoma, or alveolar rhabdomyosarcoma, but that will be more blue. It was kind of that small round blue cell differential. You can also think of picomas, paragangliomas, granular cell tumor, and metastatic adrenal cortical carcinoma. So just to recap, you have your alveolar soft part sarcoma defined by an X17 ASPSCR1-TFE3 translocation. It has this classic fibrous septae, and between these fibrous septae, you have these nested cells that have a kind of pseudo-alveolar architecture. Cytologically, these cells are eosinophilic, they're pink, they got prominent nucleoli, and you can order a TFE3 and that will stain nuclear. It's important that we get clear margins, because If not, then the surgeons will resect more, and it has a propensity to metastasize to the brain. Thank you for listening. If you liked it, give it a thumbs up and subscribe, please. And the next time, I'll see you later. Bye.